a key discussion point in the Myri community is the frequency of infections. And this is something the National Institute of Health has been studying for Myri syndrome. And we're delighted to be joined today by Dr. Stella Hartono, is a clinical fellow at the National Institute of Allergy and Infectious Diseases at the National Institute of Health. Woo, that was a mouthful.
Script.
Yeah. So as mentioned, Dr. Stella is part of the team who is investigating Myri syndrome patients and their immune response, a program we encourage everyone to get involved with. And Katie and I hopefully will be going there, hopefully in the near future. So Dr. Hartona, please go ahead.
All right, so hi everyone. So yeah, again, my name is Dr. Stella Hartono. So I am a clinical fellow at the NIH that has been working with Dr. Pam Guerrero in studying the immune system for patients with Myri syndrome. And we actually started this study in collaborations with Dr. Angela Lin. And today I just would like to give you guys a brief update on our progress. So I'm sure I'm preaching to the choir here, but again, first described by Dr. Myri in 1981, Myri syndrome is an autosomal dominant disorder that is characterized by short stature, cardiovascular abnormality, muscular hypertrophy, hearing loss, short hands, and joint and skin stiffness. But so far, I think not much is known about the immune manifestations of Myri syndrome. And when we look in the literature, in some of the studies that review the patients with Myri syndrome, about half of the patients reported recurrent respiratory or ear infections. And some of these patients were also reported to have hypogammaglobulinemia, which is like a fancy word pretty much for a low antibody level. However, no actual systematic evaluations of the immune system have been done. Patients that were found to have like hypogammaglobulinemia in the studies were just happens to have their immunoglobulin level measured. So not every patients have these measurements done. So again, I'm sure you heard about this, but I'm just going to go over it again. So Myri syndrome is caused by a pathogenic variance in SMAD4 protein, which plays an important role in TGF-beta signaling. So here's an illustration showing how SMAD4 gene and its different domain. And what is fascinating to me about Myri syndrome is that so far, all the mutations that contribute to this is conserved in two different residues. So the isoleucine 500 and arginine 496. And the mutation in these locations are thought to disrupt SMAD4 ubiquitinations or degradations, which happens in this residue, like residues 519. So kind of like a simple way to think about it is like a light switch. When the SMAD protein is intact, the switch is turned on. And because the protein is available to help signaling. However, when your cell wants to turn the signal off, they will do this by degrading the protein. So that's where the residue 519 came into play. However, because of the mutation, your cell is now unable to degrade the protein, so the signal is on all the time. So next, let's talk about how SMAD4 role in TGF-beta signaling. So TGF-beta exists as a latent signaling molecule when bind to the LTBP protein. And once activated or released, TGF-beta will then bind to the TGF-beta receptors, shown here, recruited SMAD2 and SMAD3, and then induce their phosphorylation. And once phosphorylated, SMAD2 and SMAD3 complex will then bind to SMAD4, enter the nucleus where it bind transcription, promoters, cofactors, and cause the transcription of the target gene. But as I mentioned before, we believe SMAD4 is unable to be degraded and therefore going to lead to continued signaling and transcription of target genes. Now, TGF-beta itself has a very pervasive role in the immune system. As shown here, it affects many different immune cells in a variety of ways. For our particular studies, we are mainly focusing on T cell and B cell, as these are the main immune cells that are responsible for the antibody production. So how does SMAD4 gain of function in Myhre syndrome then give rise to, possibly an immune deficiency? Is it because a defect in the B cell, a defect in T cells, or maybe it's not related to the immune system at all, and more related to the structural and anatomical issues that are common to Myhre syndrome patients? So that's kind of why we started this study. To answer this question, we at the NIH have an ongoing research study to understand how the immune system is affected in Myhre syndrome. We are looking to define the risk for recurrent infections. We're going to evaluate vaccine response, as well as looking into the prevalence of possible autoimmune and allergic diseases. So this can be done via telehealth, as well as an in-person visits to the NIH. We also trying to understand how the pathogenic SMAD4 variant in Myhre syndrome affect the immune system at the cellular level, especially again involving T cells and B cells development and their role in antibody productions. So to do this, we request research blood samples from patients who come for an in-person visits at the NIH. We do understand that traveling to the NIH might be challenging for some families. And we do offer some financial support, to an eligible families to do this. But, if that is not possible, we are setting up a collaborations with immunologists at Massachusetts General Hospitals to allow for clinical and lab evaluations to happen during your visits to Dr. Lin. So stay tuned for that. In addition to human studies, we also use a mouse model of Myhre syndrome to allow us to study the immune system in greater detail and, again, in the future to possibly test for possible treatments. Our overall goal is to improve the care of Myhre patients by being able to give better recommendations regarding your immune health and vaccination. So far, we have about 16 patients that is recruited in our clinical studies. And consistent with the previous review, over half of the patients report recurrent pneumopulmonary infections, especially during childhood. The majority of the patients report, ear infections, and some of them resolve as the patients get older, as well as a lot of upper respiratory infections, sinus infections, and occasionally pneumonias. Now, our data also showed that Myhre patients tend to have lower immunoglobulin level, specifically immunoglobulin G and immunoglobulin A, which is important for you to fight infections, in comparison to the age and gender match healthy volunteers that we show here. So a subset of the patients that are evaluated also showed lower than normal titers to childhood vaccine, such as tetanus, rubella, and pneumonia vaccine. So in general, this does not necessarily indicate a problem, especially if it has been a while since the patient was last vaccinated. So what we usually do as an immunologist is to administer a booster vaccine and then recheck the titers about 4 to 6 weeks after. And when we do this, we actually found that most patients respond normally. So, however, when you start following the vaccine response in Myhre patients over time, we found that they seem to lose their vaccine response faster than expected. So as an example, so this is a graph on the right side, on the left side, showing how the tetanus vaccine titer for one of the patients that I evaluated. So during his initial evaluation, he has very low tetanus antibody, again, can be normal if it's been a long time since, his last vaccination. So we gave him a tetanus booster and, during the 6 weeks evaluation, he responds beautifully. However, when we check his titer again, a year later, his antibody level has dropped to about a third of his initial level. And it drops even further in the subsequent year to kind of almost to the original point where we started out. What we're expecting out of tetanus vaccine titer is to have a half-life of 11 years, which is kind of why the recommendations, you got your booster every 10 years. So the next graph, the one on the right side here, shows a comparison of the antibody response, again, to tetanus between MIRI patients, shown as an orange dot, and healthy volunteers as a blue dot. So the y-axis in the antibody level, and the x-axis is the time since the last vaccinations. And as you can see here, most MIRI patients respond normally in the early years after vaccinations. But when you look longer, again, most of the healthy volunteers were able to maintain their antibody titers, while MIRI patients seems to not be able to do that. So what leads to this phenomena? So for this particular talk, I just want to focus on the B cells. So this is the immune cell that is responsible for making antibody against viruses and bacteria. So new B cells, which we call naive B cells, are made in your bone marrow and then released into the circulations. They will then encounter viruses and bacterial antigens, become activated, and either become a short-lived plasma cells that manufacture a short-lived antibody, or then enter a germinal centers. This is located in your immune organs, so your spleen, your tonsils, and your lymph nodes, and then they interact with other immune cells, such as the T follicular cells, follicular dendritic cells, and then they turn into memory B cells or a long-lived plasma cells. And this is the one that's responsible for your long-lived antibodies. So then we take a closer look at the B cell population. So this is, again, like the white blood cell population responsible for making antibodies. So usually people who have low antibody level have low number of B cells. However, of course, like with MIRI syndrome, this is not the case. So, our patients actually have higher than normal B cells, as you should see here, in comparison to the healthy volunteers. But when we look further, again, we found that most of these B cells are naive. And they have lower number of the switch memory B cells and plasmablasts. So again, this is the long-lived memory cells and the plasma cells that is responsible for making the long-lived antibodies. And when we look specifically at what kind of antibody that this long-lived cells are manufacturing, again, we show that they do have less IgG memory and IgM memory cells, and also a low IgM memory. So a lot of the IgM antibody that we see in our patients, we suspect are not produced by the memory cells, but instead by the short-lived initial response to infections. So what does that mean? So does that mean that MIRI syndrome patients have an increased risk of developing CVID? So CVID, again, this is a fancy name for common variable immunodeficiency, is an immunodeficiency disorder that is characterized by defective antibody productions. And they are defined by the following lab findings. So patients that have CVID has to have reduced IgG plus low levels of either IgA or IgM, which again, our patient shows that they do have this. And also poor and absent response to vaccines. Now with this one, it's a little challenging because again, the initial studies, when you boost the patients, shows that they have a normal response. So in some ways, then they don't qualify for this definition because the vaccine response after the initial booster is normal. So this is something that we are currently discussing about whether or not we actually have to expand the definition, about what is an actual abnormal vaccine response. And as I mentioned before, there is some thoughts that yes, maybe some of these things are also contributed by a defect in the structural and anatomical issues, right? So then we decided that we're going to generate a mouse model where the SMAD4 variant is only going to express in the immune system and see if we still see the same thing that we see in the patients. So I'm actually just get like, the data that shows that like, pretty much the mouse model that we have shows similar presentations. They all have low antibody level, and after vaccinations, they have initially normal vaccine response. And after, like, we follow them over a long period of time, we show that they're having trouble maintaining their antibody titers. The nice thing about having the mouse model is it allows us to look at the immune organs that is not accessible from the patients. As I mentioned before, the germinal center reactions happens in immune organs such as the spleen, the tonsils, and the lymph nodes, and the bone, so this is like, again, things like, that I can't really ask patients to do or, to donate to us. Although like, if any of you guys happen to have your tonsils taken out, please contact me. I would love to take a look at it. And again, like, the mouse model also then allow us to pause, to test for like, possible therapeutics in the future. And I have to say, again, like what Dr. Clementi says, I feel very blessed to be able to work in the studies. Like, Myri patients, like, when I know them, it makes my life better. So, again, thank you for like, all the Myri families that have come to visit me at the NIH and also the folks at the Myri Foundations. I also want to, thank our collaborator at MGH, Northwestern, and Johns Hopkins for their help in the studies. And I really looking forward to continue to advance our studies and hope by next year, I will be able to actually provide like, some clinical recommendations and guidance regarding the effect of Myri syndrome on the immune system. Thank you.
Thank you so much for that wonderful presentation. We have some questions if you are okay with going ahead and asking some questions. Fantastic. I think the first question is, what is your experience? And if you don't have this, please, it's just fine. We can move on to another question. Is what is your experience with IgG infusions? And have people in the study had, in your study, have they had these infusions and any positive results?
I do have some patients that initiated like immunoglobulin infusions. Now, my thoughts about immunoglobulin infusions is this. Most of the time, even if the patients have low immunoglobulin, if they're not, exhibiting kind of like recurrent infection, things like that, I usually hesitant to start it. Just because like, immunoglobulin, in fact, infusion has their own, I guess, troubles. And it's also a very expensive therapy to do. Obviously, like, if the patient has recurrent infections, then yeah, by all means, like, so the idea about immunoglobulin infection is it is to provide kind of like a passive immunizations, right? Like, like this is like immunoglobulin that we pull from like, healthy people that's already vaccinated, and the idea is just to kind of like, give this to, patients that don't have that ability. As I mentioned before too, like, that at least it shows that like, patients are able to mount the immune response. They just don't maintain it for very long, right? So my idea is like, rather than resorting to immunoglobulin infusion, then maybe like the recommendation, I mean, I cannot give this recommendation just yet.
Sure.
But like, we're still doing studies, but like maybe then just like, having like, kind of like a more frequent like vaccination schedule, for these patients.
And do IgG numbers need stability for beginning infusions?
I'm sorry, I'm not.
So if IgG numbers are low, do the IgG numbers or IgG infusions need to be done in order to make them stable? And is that, you're saying the studies haven't come back yet to determine whether IgG infusions are required or would be required for Myri patients? I think that's what you were finishing.
Yes, exactly.
Yes, exactly. Yeah. Okay.
Because I mean, and again, this is kind of obviously very different, right? Like, like we also like look into like, patients that have kind of stem cell transplant where like, they're obviously not having like full engraftment yet, so they don't have like all their B cells like kind of like fully in gear, and they don't have immunoglobulin, and so far, like, we think like, the threshold to start transfusion is actually a lot lower than what they're recommending. Again, it is hard. Every patients are different, so that's kind of why I always hesitant to kind of like just kind of like, oh, whatever the number is below this number, like do this. Yeah.
Correct. So I have another question. How should recurrent infections be treated for Mari, do you think? And are antibiotics effective? And what do we, so it's a three-part question. So how should we treat recurring infections in Mari? Are antibiotics effective? And what do we need to share with our doctors regarding this?
I think like, what you need to, okay, I'm just going to answer the last question first.
Okay.
Like what you need to share with your doctor is the fact that like, hey, again, this patient seems to have, kind of like a propensity to like, just have like a lot more illness, right? As far as like treatment, obviously it kind of depends on like what kind of illness it is. Like, if it is a bacterial, then yes, antibiotics for sure. But like, if it is like, for viral infections, then, again, like usually supportive therapy is like, what I would recommend. I do have to tell you, like, some of the patients, parents told me that like, yeah, like, the kids seem to just kind of like have a harder time kicking off their illness, to just linger longer. And again, like, that's something that we study about kind of like whether or not it is like, only completely the immune system, or like, if, again, the fact that like, some of our patients, right, like, have like just narrower airways, narrower, like, ear canals, also like contribute back and like why they're just not able to clear the infections well. So kind of like not really like them getting the illness, but like, kind of recovering from the illness.
Thank you for that. Another question is, can we say that Miri patients have compromised immune systems? And do you have any recommendations for COVID vaccines, boosters?
I would say that yes, like, I would think like the patients have like a compromised immune systems. Again, they don't qualify yet for like, the immune deficiency definition just by like, the explanation that I gave you. But for sure. Now, as far as like, COVID vaccines, like we do actually evaluated like the response to the COVID vaccines. I didn't show you the graph. But like, most of the patients that like, got vaccinated, again, shows excellent response to COVID vaccines. I'm following them over the years. So like, we'll see if they're also going to show like, the decrease. Obviously like, COVID vaccine mechanism is a little different, right? Like, it's a new vaccine, I guess like, vehicle, like, with the mRNA. So I don't know yet if it's going to behave the same as like, all your normal other childhood vaccinations.
And just by the way, a little commercial here. We think of children with Miri syndrome as children. We recommend basic pediatric health care, and that includes vaccinations. We do not have any reason to say that the vaccines would do anything detrimental, and we really do endorse all of them. Thank you.
Yes. If anything, like I said, like, we might actually need more.
And we endorse things like helmets and seatbelts and all those good style things. We are all basically pediatricians, right?
Yes.
Good point. So a little bit, another question. You mentioned that you're also studying how SMAD4 mutations might impact the presence or lack of allergies. And have you found anything relevant to Miri in this research to date?
Well, the interesting part is actually how, despite the fact that like some of the patients will come and say that, I have like, like seasonal allergy symptoms. When we look into their IgE level, which is the allergy antibody level, they all shows like very, very low level. Yeah. So if anything, like, like because like, we think this is a gain of function, this might actually be protective against allergy.
In some ways, this talk is an informal, I don't want to say an ad, but explain to you the reason why we participate in research. these topics, allergies, colds, ear treatments, all these things, these are really complex. And the best way to describe them or to understand them is to participate in a systematic, highly scientific investigation. And so if it is possible, I'm not trying to recruit, but I'm just hoping you can understand why this is so important. People have asked me, could we just get an immunology consult at home? And the answer is, I couldn't stop you, but I'm trying to say we want to integrate it into a more systematic understanding.
Exactly. I mean, we try to not just, give the benefit to our patients, but also for kind of like the broader community, right? Like things that we learn here might not just necessarily apply to Myhre syndrome patients, but it can actually apply to patients that have food allergy or seasonal allergy. Would be kind of cool, right? Like we can kind of hey, the things that we study here then can become a treatment for somebody else's disease.
And I forget to unmute myself again. I do see one more question in the chat about the COVID vaccination. Someone asked how young would you recommend someone, a Myhre patient, to get the COVID vaccine if they don't have it already?
I think right now, it is approved for 6 months and older, if I'm not mistaken. So I would, again, recommend just following the regular vaccination schedule. I don't see anything in my studies that would prohibit you from doing that. And again, if anything, I would recommend, again, following your vaccination schedules. Yeah.
Okay. Wonderful. I have an interesting question about tonsils. Since you mentioned tonsils, Katie still has hers, but if she ever had them removed, I would let you know.
Oh, thank you.
Is tonsil removal common and safe among the Myhre community?
Oh, I think as a regular pediatricians, we actually kind of going away from that unless it is something where it's impairing your ability to breathe at night, again, OSA, obstructive sleep apnea is kind of one of the indications to have your tonsils removed. I know in the old days, before, if you have a recurrent strep throat, people just oh no, just remove your tonsil, it'll be fine. But we learned that that's actually not a good thing to do. So yeah, and I think as far as kind of whether or not it is recommended for Myhre patients, I would have to defer to Dr. Lin. I would assume, just because it is a surgery, it's involving the airways, I would kind of hesitant to do that, but I don't know.
I saw Don answered this question. It's so deceptively simple. It's just 3 lines long, but it's a complex answer. And I think you gave the best introduction, which is how do we feel about removing tonsils and adenoids too, philosophically in general, right? And, things have changed over time. Number 2, what could be different about Myhre syndrome? And it's really the shape of the mouth. So some of the chins in Myhre syndrome, as you know, become a little bit longer. But it's not just the chin becoming longer, it's what we call the mid-face is smaller. So there's sort of an asynchronate. Corresponding to that, the mouth is often smaller. The posterior, we call it the nasopharynx, is also crowded. So it's sort of a crowded space. If you have a crowded space with large tonsils, snoring, apnea, difficulty breathing, that might be one indication to remove them that's really different from thinking about infections. If you have what look like large tonsils just sitting there, minding their own business, no infection, no airway compromise, that might be a reason to leave them in. So Don, there's not a simple answer to this. You do need a really sharp pediatric ENT doctor. And our doctor here, Dr. Cohen, does receive calls. In general, folks, I wanted to mention that what we can't do is we cannot be the doctors for the universe of Myhre syndrome. We can't tell you, but we're giving you information. And that information then is shared with your doctors. If a question comes up, and we get these calls frequently, I can't give you the instruction, but if you get your doctor to call or email me, 100% of the time they'll get a response in some way. And so it's for challenging issues like this, okay? And the exact frequency, Don, of how often it's done, I'm not sure. I just don't have the percentage, sorry.
And to echo what Dr. Lin said, like, if you decided to get an immune evaluations in your home institution for whatever reasons, and your immunologist wants to get more information, feel free to give my number. I would love to talk to them. Again, we're very collaborative. Like, we all want, like, like the best for our patients. So
here's a question, Stella. You did mention your interest in receiving any surgical specimens of tonsils, and that is doable. How would somebody get that to you? They would inform their ENT doctor. I know this doctor at the NIH, and then continue from there. How would they make that connection happen?
So, like, prior, I mean, obviously, like, when you schedule the surgery, then, like, just contact, like, me, or like, the my, like, nurse study coordinator, and then, like, we can then arrange with your ENT doctors, like, like the shipment and, like the transfer of the material.
Doctors generally know, surgeons generally need to know into what kind of a container do I put the specimen?
Yep.
How much is needed? Does somebody have to pay for this to get to the NIH, and so on? And those are actually things that can be answered. You just need some cooperation at the other end. And to be honest, sometimes surgeons are just so busy doing the surgery, they may not think about this. So you want to just plan in advance.
Yeah, and we'll take care of, like, everything from, like, we'll send them the container. We'll make it as painless to them as possible. It's pretty much, what I always try to do.
We're going to have more questions. There's actually too many for me to ask you all of the questions today, but I'll ask one more. But just so you know, so I'm monitoring the Zoom. I have text messages. I'm getting messages on Messenger. So I have a lot of questions for you. But for Dr. Lin, someone just sent me a message and said, "Who is that other lady, that lovely lady that keeps talking with Dr. Hartono?" And I'm like, "That's Dr. Lin." And so we had not had a chance yet to introduce you. So to the Myri community who have not had the chance to meet Dr. Lin, again, right after lunch, you'll have she'll introduce herself and do all that. But yeah, so the other lovely lady, apart from Dr. Hartono, is Dr. Lin. It keeps chiming in there and answering wonderful questions. So one quick other question is, do you examine the role of TGFB? Because of the effect on general inflammation, it might increase allergies or autoimmune reaction?
We think it's actually, again, with the Myri syndrome being a gain of function, we suspect that it would decrease predisposition for you to develop allergy. Now, with autoimmunity right now, it's like something that we still continue to follow. A lot of, like, again, not necessarily related to Myri, like, other, like, immune dysregulation, immune dysfunctions that I study with low number B cells, often sometimes, have a predispositions to development of autoimmunity. I have not seen it so far, but, that's something that we're looking into.
All right, and I think we have just enough time for just one more question. Does the study have an end date, or can people still get involved after the new year?
Yes, people can still get involved. We're continued enrolling on a rolling basis. Yes. And again, like, I know time is short. If you have any other questions, I mean, you can give them, like, my email address. I would be happy to answer any and all questions.
Wonderful, wonderful. Okay, well, one other one just popped in. Are there ways we can naturally boost the immune system?
Oh.
Very broad question.
Yes. Yes. So naturally boosting your immune system, obviously, again, like, eating a healthy diet and exercise would be something I recommend highly. People underestimate kind of like the effect of nutrition on your immune system. You can actually, like, just, by, like, being anorexic, like, like, you can actually, like, just kill your immune system, really. so that's that. Like, again, I mean, I know people like doing immune supplements and things like that, but I think, like, like that's something that if you're gonna initiate that, like, discuss that with, like, your primary care, doctors or your pediatricians. They're great resources for this.